Welcome to 3 Ps on a Pod, the PSHA podcast where you get to hear from the current, past, and future presidents of the Pennsylvania Speech, Language, and Hearing Association. I am Nicole Billak, the current president of PSHA.
Hi everyone, I'm Craig Coleman, president-elect of PSHA. On this podcast, we'll bring you conversations about the challenges and opportunities in our field, highlight important updates, and share ideas that help professionals stay informed, connected, and supported.
And I'm Erin Buckwater, past president of PSHA. We'll also be talking with colleagues, leaders, and experts from across the state and beyond to share insights, experiences, and practical information that matters to our community. Let's get started.
Hello, everyone, and welcome back to 3 Ps on a Pod, the podcast from the Pennsylvania Speech, Language, Hearing Association, where we break down the issues impacting our profession. I'm Nicole Billak, PSHA president, and today we're diving into one of the biggest topics currently affecting speech-language pathology, CPT code 92507, and the proposed shift towards new, more specific time-based treatment codes. If you've been hearing conversations about time codes, RVUs, or concerns about reimbursement or clinical impact, you're not alone. There's a lot of confusion and a lot of concern and a lot of questions. So today we're bringing together experts from across PSHA to walk you through what we know so far, why it's happening, and what it means for you in your practice. PSHA formed a task force a few months ago to tackle this task. And we've been investigating this issue, and we'll share with you what we found and what we're permitted to share. Before we start, it is important to remember that these are proposals, and our comments only reflect our task force findings and opinions. You may have differing opinions from what our panel presents today, and that's okay. We encourage healthy and professional dialogue. It may seem that this is a very secretive process, and that's because it's designed this way. The AMA, or the American Medical Association, has very strict guidelines on lobbying. Here is the purpose that the AMA provides to discourage lobbying. The CPT policy on lobbying and proper communications establishes standards to ensure that the CPT editorial panel works is conducted with fairness, transparency, and respect. It is designed to safeguard the independence of CPT editorial panel members by protecting them from unsolicited communications before and after submission of a code change application. Safeguard the independence of CPT advisors and their specialty associations or societies by preventing communications that are meant to improperly influence the evaluation or comments on a CAA. Ensure that communications after the submission of a CAA are managed through AMA staff and promote transparency and fairness. Promote participation by stakeholders in the CPT process that is free from harassment, intimidation, or coercion. This CPT process and lobbying and proper communication applies to all participants in the CPT process, including applicants, CPT advisors, specialty societies such as ASHA, interested parties, and panel members. Everyone on our panel today has signed a non-disclosure agreement as an interested party, so we can't reveal everything that we know. However, we want to share what we have obtained permission to share, to calm some fears and reunify our profession a bit so we can get back to doing what we love, helping people. I'm joined today by an incredible group of leaders. We have Joanne Wisely. She is PSHA StAMP, which stands for State Advocate for Medicare Policy. We have Akila Rajappa. She is the current VP of Professional Practices and our President-elect. Jill Shook, our Private Practice Committee Chair and Private Practice Owner for the past 11 years. And Emily Aten-Newberry, the previous Private Practice Committee Chair and Private Practice Owner. Thank you all for being here today.
Thank you, Nicole.
Thank you, Nicole.
Thank you. Let's start with a quick overview. In 2024, CPT code 92507, which is our primary speech therapy treatment code, was flagged for potential overuse. As a result, the AMA, ASHA, and the CPT editorial panel have been working towards restructuring how speech therapy services are coded. The proposed direction is to move away from a single untimed generalized treatment code and instead move towards more specific timed treatment codes, similar to other therapy disciplines. This has raised a lot of questions about reimbursement, scope of practice, and access to care. So to really understand where we are, we really need to start with some basics. Joanne, would you be able to walk us through how the CPT codes work and give us some historical context? Have we been here before?
Yes, Nicole, we have been here before. To give a little history about CPTs, we have to think of what the title actually means. CPT stands for Current Procedural Terminology. When you think about what that means, it is supposed to reflect, these codes should reflect what current procedures are for the healthcare services that are being provided. A very long time ago, probably before most of us were born, the medical profession had to write everything in a narrative form. When they explained what they did, it was in a narrative form. Longhand, medical records, no coding, no shortcuts. It wasn't until 1966 that the American Medical Association presented the first group of CPT codes, and that was an intent to be able to identify what was actually happening during surgeries. So when surgeons were providing services and doing operations on patients, there was inconsistency in the amount of information that was being provided after the operation. What they decided to do is they needed some standard for not only themselves to know what the members were doing, but what should be expected of the patient on the other side of surgery. So they started with this 4-digit CPT code in 1966. It didn't take long for them to realize that there were so many procedures being done by so many different types of healthcare providers that by 1970, they went to a 5-digit process, similar to the CPT codes we see today. Keep in mind, CPT codes were for medical procedures, for services that were being provided by physicians and other healthcare providers. It wasn't until 1983 when CMS decided that if they were going to be providing and paying for services to Medicare beneficiaries, that they were going to use the same standard that AMA was using to measure their own physician services. And that's when CPT codes became not only medical descriptors, but also used for reimbursement. The rest is history, because since 1983, you have had a whole series of Medicaid programs, private insurances, just about everyone using CPT codes to not only define the service, but also to determine the reimbursement. What does that mean to a speech pathologist? Well, I have to openly admit that I have been practicing long enough to remember when we had one code for speech therapy. Everything was speech therapy. Then our practice grew. And when we were doing a speech eval, it wasn't just a speech eval for articulation or for fluency. It was for speech and language. And we really didn't have a code that defined the speech and language evals that we were doing. About the same time, we started looking at ourselves as the professionals, the preferred professional for swallowing disorders. And we were doing dysphagia evaluations. We had a clinical dysphagia eval. Well, certainly that did not fit under a speech eval. So as you look at the history of our profession, we now have a speech evaluation, a speech and language evaluation, an aphasia evaluation, a comprehensive cognitive evaluation, a clinical dysphagia evaluation, a video fluoroscopic, a FEES, the list goes on. And this is all as a result of our practice and our profession growing and expanding. When you look at it from that perspective, from a historical perspective, we come to realize that what we do today is much better defined as a result of the CPT codes that have been developed over the years, as painful as it has been, And I admit to you, it has been painful. But now I can very carefully and clearly say that when I use a certain code, people know what I'm doing. So this is something that I think is helpful for us to keep in mind. Now, the CPT process is complicated. And there are ways that CPTs come out and they may not be perfect. And through the years, we have had CPT codes having to be refined. We have had CPT codes discontinued. So these are things to keep in mind. It's a never-ending process, and it's a growing process. Now, as to what goes into a CPT code and what is thought of in the formula to decide exactly how that CPT code should be used for those clinical procedures, I'm not going to get into that, but I'm going to let Akila help us with that one. So Nicole, hopefully that helps with a historical perspective. And I'm going to go back to you and let you take it wherever you want to go with it.
Thank you, Joanne. That is really helpful, especially understanding that that's not the first time our profession has had to adapt. Akila, one of the terms people keep hearing is the RVU. Is there anything you can do to help explain that, what it is, how it really impacts reimbursement?
Absolutely. I know there's a lot of anxiety and conversation right now in the SLP community surrounding this code. We hear those concerns. They're absolutely valid. But to really understand what's happening behind the scenes for this 92507 code, we first have to understand the mechanics of the system, which drives the reimbursement in healthcare. So basically, this system is built around something called RVUs, which is called the relative value units. And Medicare and most commercial payers do not randomly decide what to reimburse for healthcare. So they quantify this. So instead of every CPT code is assigned usually it's assigned a numerical value that's called the RVU. And then this RVU is actually multiplied by a national conversion factor to determine our reimbursement dollars. So what exactly is this RVU? It's essentially it's a method by the healthcare system to quantify the value, the complexity, and the cost of delivering your SLP service. It's not just one arbitrary number. It's made up of three major components, which include something called the professional work expense, the practice expense, and your malpractice expense. So when you talk about professional work, the RVU, that makes up for about 50% of the total value of the RVU. So what does it include? So it includes clinician's time, your specialized knowledge, your technical skill, your mental effort, and your clinical decision-making, clinical judgment associated with whatever we do. And then the second component, which is a practice expense RVU, that makes up for 45% of this total RVU. So that includes like cost of running your practice, like your clinic space, your rent, your equipments, your technology, your electronic documentation record, the EMRs, and any speech therapy materials, your administrative staff, the utilities, and all of the infrastructure you're using to provide treatment. So that's 45%. And finally, the 5% includes malpractice expense, which is nothing but a professional liability, which is required for our risk associated with all of our practice. So when you put this RVUs into perspective, like I want to kind of go back from what I learned from ASHA's recent talk, was that, for example, if you want to put into an interdisciplinary perspective, like think about a surgeon, what Joanne was saying was, if he was doing a neurosurgeon doing a highly complex medical procedure, something like an 8-hour craniotomy, so that will take about 22.8 RVUs. Whereas a physical therapist, your colleague, he or she can build 15-minute increments, and that may carry about 0.44 RVUs. And currently, our primary SLP treatment code, which is 92507, that carries about 1.3 RVUs. And then something like ear piercing, which is non-skilled, which has no medical necessity or clinical complexity, can carry essentially no RVUs. So these comparisons are actually helpful for us because they remind the importance of RVUs. They're intended for representation of intensity, expertise, and the resources associated with your healthcare service. And to put this into more perspective for our speech therapy specific examples, I want to highlight two examples. One from a pediatric childhood apraxia of speech case, another one is from a voice disorder in adult medical setting. So if you take this childhood apraxia of speech, imagine a 45-minute session with a 4-year-old child with moderate to severe childhood apraxia. Your professional work, RVU, would reflect more than just playing with this kid and then doing all your fun games. No, that's not what we do. So you're talking about intensive cognitive, speech, motor, and clinical demands that you're being placed on the SLP. You're constantly analyzing speech motor planning accuracy. You're monitoring jaw and tongue movements. You're adjusting cueing hierarchies in real time. You're implementing evidence-based motor regulation approaches, something like dynamic temporal tactile cueing. I'm just throwing a few evidence-based programs out there like prompt or whatever, and you're managing attention and regulation of the child. You're pushing for high repetitive practice. You're using motor learning approaches, speech exercise physiology, neuroplasticity frameworks, all of this while maintaining engagement with this child for 45 minutes. And your work doesn't just begin or end with that. You're talking about, then you're going into reviewing prior performance data, you're selecting speech sound word targets, you're documenting the encounter, you're counseling families, and you're creating carryover strategies. And then this is just professional expense of 50%. We're going on to practice expense. What does that include? Your therapy room, your materials, your AAC support systems, your mirrors for visual feedback, your printed and laminated resources, your technology platforms, your billing systems, your administrative support staff who make all these sessions possible. And then we have this 5% malpractice, which with caregivers and families, we're always going to need that. And then, so that's about pediatric. So now moving on to voice therapy. So when an SLP sees a patient, say, for example, with muscle tension dysphonia or a vocal fold lesion using the 92507 code, so the clinician is performing highly specialized physiological treatment. So your professional RVU reflects video stroboscopic administration, constant auditory perceptual monitoring, you're analyzing vocal quality, you're working on respiratory coordination, laryngeal tension, you're making real-time clinical adjustments. All of your speech science work, you're literally implementing it in a session. And then your practice expense will include your stroboscopy maintenance equipment, disinfecting supplies, microphones, acoustic softwares, biofeedback system, recording equipment, and then you also want an acoustically appropriate treatment space. You can't just provide voice therapy in the gym. You need a private space to work on their voice quality, and then sanitization protocols. So these are not just generic office visits. These are highly specialized healthcare services requiring advanced expertise, ongoing clinical decision-making, and significant infrastructure. And malpractice is a whole nother 5% which you need. So that was just a general overview. Thank you.
Well, thank you, Akila. That really helps. We definitely understanding the RVU is not just one number. It's definitely made up of the work RVU, the practice expense, which we have a lot of practice expense, a lot of equipment that's needed. Things have really changed. And then you obviously have the malpractice on top of that. So, the numbers we're seeing out there aren't necessarily reflecting all of those values. And so I think that's really helpful. Thank you so much. Appreciate that.
Sure. Welcome.
Awesome. All right. So now we're going to shift into some frequently asked questions that we've been hearing from our members. PSHA and other state associations have been collecting questions and forwarding them to ASHA on your behalf. As a result, ASHA has obtained special permission from the AMA to share their proposal with state leaders. And most of what was presented to us, we can share today. There will be some things that the AMA did not give permission for ASHA to let us share. And so we'll talk a little bit about that. So most of the things, though, that we've been asking from ASHA, they were allowed to give us those answers to. So I'm going to bring in Emily and Jill. They're going to help guide this part of the conversation. Emily, what questions have you been getting from the Private Practice Committee about 92507?
We are definitely getting a lot of questions, and there are a lot of concerns over what will happen next, and all of that is very valid. So, Nicole, a big concern that we're hearing is that it looks like 92507 was devalued. Is that actually the case? And if so, how do practices, including my own small private practice, will survive this?
Right. So it's not a simple devaluation of our code. It's really more of a restructuring. I think the biggest point of confusion is the 1.3 RVU number that people are seeing attached to 92507. That 1.3 reflects only the work RVU that Akila was referencing earlier. It does not include the practice expense at all, or we call PE value. We also have the malpractice expense that also goes into that. So that distinction really matters because reimbursement is not based on work RVU alone. It's based on multiple components, and the PE portion is a significant part of that total value. So when people compare the old 92507 work RVU of 1.3 to the new proposed 30-minute codes at roughly 0.8, 0.9, we're actually not comparing the full code. We're only in those cases looking at the work value. And there are the practice expense that goes into both of those. So even though at first glance it's going to look like our services are cut because 0.8 and 0.9 for the new codes is lower than 1.3, that does not take into consideration the practice expense value entirely. So it's really not a true apples to apples comparison. Really leaves out a big 45% of that portion, which will definitely be valued at something that is reflective of how expensive it is to be able to give these services nowadays. It is very expensive for rent, and there are a lot of things that we need to be able to capture in our new practice expense. So ASHA argued that while the work value is lower, those new codes are built around, even though those codes are built around those shorter increments, that practice expense should be much higher today because of that complexity. We have more technology, more demands. If we think about how our practice has changed just since COVID, we're doing this on Zoom. I didn't know anything about Zoom until everything came out for COVID. So there's been a lot that our field has had to adjust to since these codes have been looked at last time. So the important takeaway is this: the 1.3 number that we're using for 92507 is just one of a third of that pie that we're using. Looking at the RVU alone will make it, for work value, will make 92507 look devalued, but the full proposal will include a substantial amount for the PE value as well. So those are not apples to apples comparison. Doesn't mean that just because 8.8 is lower than 1.3 that we're going to end up with a devalued code and therefore devalued reimbursement.
That's great, because as you said, practice expenses have definitely gone up, and Akila went into a great rundown of all of the expertise that we need to do. And it's not just, parents might see, oh, you're just doing this one thing. And no, we're multitasking on a constant basis. So that's wonderful to hear. Thank you so much.
Sure.
I wanted to add one more thing, Nicole. So I forgot to mention that, these RVUs are actually determined through clinicians' participation, clinician data. So that's how organizations like ASHA and AMA rely heavily on our survey data through something called the RUC process, which is called the Relative Value Scale Update Committee process, to help determine how these services are valued. So that's why these surveys are critical. And then they are used to estimate the time, the intensity, the clinical effort, and the practice expense associated with services like 92507. So I just wanted to mention that it's not some random number. So it's definitely taken, clinicians are taken into consideration, to evaluate this.
Yeah, absolutely. Thank you, Akila. Appreciate it. All right, Jill, you're up next.
Help if I were not muted. So when I look at these new CPT codes, I don't see one for auditory processing or for communication, which is what 92507 currently includes. So does that limit our scope of practice with these new codes?
So no, CPT codes do not define our scope of practice. Only the state licensure board, professional training, and clinical competence can do that. In Pennsylvania, our licensure board has not indicated any plans to narrow our scope of practice for speech-language pathologists. So we're not concerned about narrowing that at all. So when people notice that terms like communication or auditory processing aren't listed as separate CPT codes, that does not mean that those services will now fall outside of our scope of practice or not be reimbursed for. Part of what's driving this is how the AMA views coding. If two services are typically provided together for a large portion of the same session, think about the kids that you see for language and speech. The AMA generally prefers that those services be represented under one combined treatment code rather than having multiple separate codes trying to stack. So communication is a great example of that. In a typical session, you can be targeting speech clarity, language organization, syntax, narrative skills, and all kinds of other related areas all at one time. And under ASHA's proposal, their services would still very much be billable. They would just simply fall under the combined speech language treatment code rather than having a separate communication code. And the same thing applies for auditory processing disorder. Treatment by SLPs for APD have generally been considered part of a speech language intervention. And under that new proposed structure, that would continue to be captured under the combined speech language code. So bottom line is this: the absence of a separate CPT code does not mean that the services disappear and that we won't be reimbursed for them. It means that the service is just going to be grouped differently for our billing process.
Oh, okay. That makes sense. Thank you.
Sure.
So it seems like ASHA has definitely proposed 30-minute base codes instead of 15-minute codes increments because of how CMS, the Centers for Medicare and Medicaid Services, applies payment reductions when multiple therapy services are billed on the same day. So Nicole, Akila, how is that reduction applied in the medical setting?
Oh, I'll take that, Nicole. Thank you for that, Emily. So in medical settings, we all work in an interdisciplinary setting. I think, you all work as part of a gym. So PT, OT, ST, we're all together, right? So, and patients, when they come in, so they often receive PT, OT, and speech therapy services all in one day. So now when you look at the payment reimbursement, so the Medicare may reimburse usually the primary therapy service fully, and secondary and then the secondary services units are actually only receiving reduced payment, especially with a 15-minute coding structure. So that reduction actually affects multiple units. So I think from our understanding, ASHA, that's why I argued moving into a 30-minute code, so you can actually simplify the billing and reduce some of the financial impact of those reductions. So I would like to explain it from for example, a patient in a skilled nursing facility after a stroke. Say for in the morning, the physical therapist works on walking and balance for 45 minutes. And later in the day, the SLP provides 30 minutes of dysphagia therapy. So under this, or dysarthria therapy. So under the current 15-minute coding structure, PT may build 3 15-minute units, and SLP may build 2 15-minute units. So now Medicare reviews all those 5 units built on the same day, but typically the highest valued service is reimbursed fully, while additional services are only given half the reimbursement or reduced totally. And so instead of every therapy unit being paid 100%, some of the later units are actually being reduced. So from ASHA's perspective, this becomes so complicated because speech therapy is often delivered in a PT/OT medical setting. So their concern was that 15-minute units actually increases the chances of payment reductions being applied across therapies, and which is why they came up with, they're suggesting is 30-minute coding. So basically to simplify, to better reflect your clinical real sessions and also reduce the multiple procedure payment reductions when patients are receiving several therapies in one day. I think many managers and, they will probably resonate, this will resonate with them. So this is the scenario.
Awesome. And Jill, I think you see this in private practice as well, right?
I do, yeah. And I have seen that in my own practice and then when I'm working with people. So for example, like you bill 2 SLP codes in one day, you're billing maybe like 92507 and 92609 because you're working on language skills and AAC. And then the code that is valued less would be reduced. So it would be helpful to be able to have that 30-minute base code, because again, with 92507 being untimed, you could see a child for an hour and it would not affect how much you get paid versus seeing them for 30 minutes. So it would be nice for the codes to finally be like the time that we're spending to finally be more valued.
Absolutely. Definitely. I mean, and that's exactly it. The logic kind of works for those longer sessions as well. If both therapies, let's say 45 minutes for PT and 45 minutes for speech, if they were both at 45 minutes, PT would essentially get their first 15-minute code at 100%. But then everything after that, their next two codes are going to be reduced. In our case, for speech, we get the full 100% for 30 minutes, and it would just be our add-on code that would be considered at a reduced rate. So actually, when you're working in a medical setting like that, it's advantageous for the bulk of your code to kind of be under just that first one. So really kind of thinking about that, it's practical. It's a practical decision. Really helps protect that reimbursement for speech therapy, particularly in medical settings, but also where multiple therapies are really just being provided on that same day.
And I think that definitely makes sense for sure. Yeah, absolutely. Because, survey results showed that most of us do see kids, in private practice and in schools. And, I'm in the pediatric world for 30 minutes. And so starting with a 30-minute code definitely makes a lot of sense. Thank you.
So to kind of pivot back to this timing and this 92507 code that we're talking about, a lot of SLPs have been wondering, why are we changing it? Why can't we just keep 92507 the way it is and just keep billing the way that we've been doing?
Right. Yeah, change is difficult. We totally understand that. The problem, though, is that 92507 was flagged by the AMA for its overuse and lack of specificity. Basically, the AMA wants a clearer coding structure that really better reflects the different types of intensity of services that we are providing. So more specific codes will actually align better with other healthcare trends, where payers increasingly want that bigger amount of detail on that treatment that was provided. So if we simply kept 92507 exactly the way it was, we would essentially be arguing that our work today looks exactly the same as it did when the code was originally valued back in 2014. ASHA was concerned that could lead to a lower work value and no change to even maybe a decrease in that practice expense value. That would ultimately end up with a lower reimbursement rate for providers. So the concern wasn't just changing the code for the sake of changing. It was to make sure that the coding structure really better reflects that modern practice and really kind of protects the value of our services as well.
And that's a really good point, bringing that up because, we've heard many concerns, many questions about the survey where the AMA asked about 92507. Why was the sample so small? What did it actually show? We all know that over 9,000 SLPs were surveyed, but less than 90 responded.
Mm-hmm. Yes, and that was one of the biggest concerns our task force expressed as well. They were concerned and disappointed with the low survey response rate. The frustration with that is definitely understandable. But it's also important to know that that's just not unique to speech language pathology. Both ASHA and state associations and other state associations outside of speech pathology have seen lower participation when it comes to these surveys that are going out. And this is why feedback matters so much. When the survey comes out from ASHA or from us, your state association, those responses are actually really used to help shape the data that's used to make decisions that are going to affect us. And so I know it takes a lot of time, but it will take a lot less time for you to respond to them early rather than us have to change an outcome later. And from the standpoint of the AMA, the survey still met their minimum threshold to be considered valid. The AMA requires 50 responses and also expects that the data collection process meet that certain research standard so that they can use that in their valuation decisions. And the AMA requires the use of a third party to ensure that sample results are double.
Just real quickly, and it looks like you unfroze. So, but the other thing that just to keep in mind with 92507 is to think about, again, with the history of CPT development, 92507 has been in existence for a very long time. And if we think about how our practice has changed, does it accurately reflect all that we're doing under the code? And that's something that, although I know changes can be painful and that we're not real comfortable with the idea of changing, this is one of those examples that I said that over the years, some codes have been discontinued and others have been revised. So that may be what we are experiencing at this time. Time will tell, but I think that's something to keep in mind. I'm sorry, Nicole, you're back, so you can finish your sentence now.
No worries, no worries. I'm hoping that you guys heard me talk about the 50 survey responses that the AMA requires. But it is important to understand that they do require the use of a third party for results to be double blinded. So it's not like they can go out and recruit people for this survey response. That would definitely interfere with the level of evidence that the AMA requires to use all of that.
And I think that's a really important point to bring up, that, the AMA is requiring a third party to do this. This is not, ASHA has 240,000 members in it, and why weren't more people, contacted? Valid question. I hear your question. A third party sent it to 9,000 people, and those are the number of respondents that actually happened. But it's good because the survey showed something that our task force largely agreed with. Most clinicians are not using 92507 as a full 60-minute treatment code anymore in everyday practice. So there is this balance. If the data suggests a lower work value, but there's no corresponding increase in practice expense, that combination could negatively affect reimbursement. So the goal here is, of course, to reflect real-world practice patterns without creating this unintended consequence for SLPs, for us providers. We all want the same goal: keep our doors open to help as many people as we can, while also honestly making a living for ourselves that do reflect master's level expertise with many hours of continuing ed. So that's really important, and state organizations, we're definitely pushing for that.
We definitely we all want the same thing.
We do.
Absolutely.
And now to kind of talk a little bit about the elephant in the room as far as reimbursement. So how could this impact the already egregiously low Medicaid reimbursement in Pennsylvania? This affects more than just private practice owners. It affects anyone who works in a school that bills Medicaid. It affects hospitals. Anyone who bills at all. The low Medicaid reimbursement is awful. And how does this code change affect that?
Absolutely. And renegotiating that Medicaid fee schedule has been a top priority for PSHA for a very long time. Unfortunately, change doesn't happen very quickly, particularly when it involves our legislature or anybody else who's kind of running things, because there are a lot of things that go into that fee schedule. But currently, PSHA has the lowest reimbursement rate for speech therapy in the continental United States. It's just $21.73 a session. That is not sustainable. We have met with DHS, who oversees Medicaid in Pennsylvania, many times in the past few years. But with the uncertainty of Medicaid at that federal level right now, we're not sure what kind of reimbursement we're going to get with that. And so our state has really been reluctant to improve those rates for us. Unfortunately, though, we're starting to see therapy deserts pop up in those rural communities. Therapists can't sustain a clinic on $21 a session. So providers are either refusing to take Medicaid clients or they're closing altogether. Medicaid rates really impact us all, regardless of whether or not you're using that program. If your favorite provider can't operate based on the reimbursement they're getting from Medicaid providers or patients, they're going to close. And changing that 92507 code, ironically, gives us a unique opportunity here in Pennsylvania. If 92507 is either eliminated or remains a code with offering additional treatment codes on top of that, the DHS is going to be forced to look at our rates again. Based on the early and periodic screening, diagnostic, and treatment rule, Medicaid benefits are required to be provided by states for early intervention services. And therefore, DHS will need to have a plan to ensure that they're compliant with that rule. And by introducing new codes that are more aligned with current healthcare trends, we have actually a new opportunity to negotiate a much fairer fee schedule for our therapists in Pennsylvania. We do have meetings set up with DHS and Secretary Valerie Arkush to talk about the changing codes. And so we are hoping that this can be an opportunity to work with the state to make sure that we're providing a fairer fee schedule for our therapists in Medicaid. All right, before we wrap up, does anybody have any final thoughts or advice for our members?
I think this was really helpful. I mean, I'm still learning more about this coding process. I think all of us are. We never knew how this whole CPT code procedure happened, and now we're learning more than we ever, I think, wanted to know. But I think it's great. I'm looking forward to seeing how this can affect us moving forward.
And hopefully, like we're all saying, it's definitely a positive change for us. You know, Joanne has mentioned at the very beginning, there was one code. I can't even imagine having one code for the depth of information that we know and the different types of patients, and even just within the pediatric population. And we can treat pediatrics and adults. And I think, you know, change is very hard, but I think it's so important for us to really reflect what we are doing and what we know and how long we are doing this with patients. So we're going to see what happens.
Still a lot of unknown answer or questions out there. The answers, I can share that ASHA is a little bit further along in the process than some of the other proposals in there and have started looking at reimbursement rates. Now that information is specifically precluded from the allowable information we're allowed to share. However, ASHA did share with state association leaders what their negotiating rate is for a base code. And I cannot tell you what that is, but I can tell you that we were very happy with what they were proposing. So things are definitely moving in the right direction. We are happy with the proposed reimbursement. Again, anything can happen before that final rule comes out. We should hear a little bit more on the final AMA recommendations by May 15th. However, that final rule from Medicare won't be fully released until July. So anything can happen. However, the proposal that we've heard from ASHA has a pretty decent value associated with reimbursement at this exact moment. So we'll kind of keep it at that, and we'll keep everybody informed as more information comes available. Anybody have anything else they wanted to share?
So, Nicole, so I just wanted to clarify here. So right now we are of the understanding that any projected increase or decrease, I'm hoping increase in the reimbursement. That's what I think you're giving us the, potential good news. So it remains hypothetical until the final RVUs are finalized and adopted by Medicare. So that's what I'm trying to understand here. And eventually, I mean, Medicare and commercial payers, right? So this process is actively evolving.
Right, exactly. This is actively evolving, but what has been proposed by ASHA it has made the people who've heard that proposal very happy. And we don't want to give away too much because we want to keep moving in that direction. We want to keep working with the associations to make sure that speech therapists are adequately reimbursed for their services. So yes, we'll keep everyone in touch. Yeah, go ahead.
Yeah, no, I'm just hoping that, as we move from 1.3 up, now that I understand what this RVUs is about. So as we, hopefully as we move from 1.3 to maybe I'm hoping like a 5 to 6 time, 10 time increase. I'm just saying that, I mean, if not as complex as a neurosurgeon, but SLP, we absolutely deserve great respect for our expertise and be valued so that through this quantification approach, with consideration to all our task-based services, hoping that this will boost our RVUs for better financial compensation, reimbursement, better practice, and ultimately to serve the patients in the best possible way. That's all we all want to do. So,
absolutely. Well, thank you everyone for joining us for our episode on PSHA Perspectives of 92507 through the 3 Ps on a Pod podcast from PSHA. We hope everyone stays in touch, and we will be back with more information when we hear it. Thank you.
Thank you. It was an honor to join you all today.
Thank you.